First things first, I'm going to have you do a little brief introduction on yourself and what your credentials are.
Thanks very much for having me on the podcast, Lexi. I really appreciate it. Just a little bit about myself. I have a doctorate in physical therapy, and it didn't start that way, though. I actually started in orthopedics and sports medicine.
Oh, interesting.
Yeah, so that we'll get back to later because there's a reason,
Hmm.
that's part of the story. Talking about endometriosis, but I actually started out as a licensed athletic trainer, which meant I did sports med. I took care of athletes, not paying attention to like endo at all, in fact. And then things came full circle, and let's see. Oh, this year would have been my 30th year as an athletic trainer, so 30 years of that,
Wow.
and 27 as a physical therapist, and it's been a wonderful journey of learning about the inadequacies of medicine, really, and of
Hmm.
therapy, of what it doesn't include that it should include, like integrative therapies, lifestyle
Hmm.
medicine,
Yeah.
a real public health emphasis, empowering patients. Um, and then, what it did include pelvic physical therapy and manual therapy and, visceral work and imaging and dry needling and all of the things that we use that are really life-saving modalities in terms of quality of life. But
Hmm.
that just led me in this kind of circuitous route, path to come full circle because I use both backgrounds, obviously. Um, and then somewhere along the way, I found time to do a couple of books and some book chapters and articles on therapeutic yoga
Hmm.
and integrative and lifestyle medicine. That's how I came to really specialize in endometriosis, is really through a complementary and integrative medicine lens. And,
Interesting.
without the reason I think is because so many people with chronic pain would
Hmm.
then ask to see me, and they start traveling from further distances to see me. And when women have chronic pain, what's one of the drivers? Endometriosis,
Yeah.
um, and, in my own journey, which I've been vocal about on YouTube and other platforms, I came to have my own journey with endometriosis. So it really was this kind of circuitous, like full circle path of going, wow, I have learned so much in 30 years. So I look forward to
Yeah.
sharing it. That's my 2 cents.
I'm so excited. I'm so happy to have you on the podcast. And I think that you have such a wealth of knowledge that so excited to share with both of our communities more. And I know I saw that you put out a mini guide on is it endometriosis, pelvic floor dysfunction, or a hip tear? And I think that's really interesting. When did you put that out?
Oh my gosh, that was
Hmm.
just recently because I did a couple of podcasts on determining whether it's one or the other. And it's
Yeah.
something I feel pretty passionate about because I've had too many patients who've actually had hip arthroscopies, and it was actually endometriosis as the problem.
Interesting.
Yeah. And that's a massive surgery. I mean, that's really big surgery to have excision and a really big surgery to also have hip arthroscopy.
Yeah.
A surgery to avoid if possible, especially if it's not the hip.
Yeah. I thought that that was really cool. That little mini free book just kind of talking about which thing do you have. So I'll definitely link that in the show notes too for
Thank
people
you.
to go look at.
Okay.
Um, so your background and your experience with endo, when did you get diagnosed? And what did that
Oh,
process look like for you?
the process was fraught with medical gaslighting
Yeah.
and self gaslighting
Hmm.
because if you're told from day one, if the first time you ever have your period, it's horribly dysfunctional. But if your mom's was, or your
Yeah.
grandmother's was, or everyone's around, and then you go to a OBGYN and they're like, oh yeah, it's just part of it. Here's
Mhm.
some birth control. You know,
Yeah.
stay on that for 20 years and see how that
Yeah.
works. Then you just gaslight yourself. You're
Hmm.
like, oh, well, maybe I do have a low tolerance for pain. But then over the years, you begin to normalize more than that. You begin to normalize horrible gut pain,
Hmm.
digestion problems, respiratory pain, just breathing. Just
Mm-hmm.
breathing is excruciating. But then back pain, hip pain. You start to normalize all of that and you find other reasons for it. So my journey is a long one. It's 36 years
Mm-hmm.
before I got a diagnosis.
Oh,
Yeah.
that's awful.
So that means it started really prior to me ever pursuing any kind of degree at all in healthcare, not
Yeah.
knowing absolutely anything, but then developing an incredibly high tolerance for discomfort because everyone around you is telling you otherwise.
Yeah.
Either that you need to suck it up, buttercup, or that maybe you just don't have a high pain tolerance at all. And so, but by the time I actually had 3 kids, which is a miracle in itself,
Yeah.
by the time I experienced that, um, and I had all of them with no pain medication, I learned that I did, in fact, have a high tolerance for pain.
Yeah. Uh,
And yeah, and other things where I would go in for a procedure and they're like, "You're not flinching. This should really hurt." I'm like, "No, don't feel it. Does not
yeah.
hurt." Um, then
It's such
I
a common experience too with people
yeah,
with endometriosis because you're told that you have a low pain tolerance for so long that you believe you do.
yeah.
I think the funniest one for me was my freshman year of college. I broke my foot, like shattered it, didn't
Mhm.
realize it. And I walked on it for a week. And then finally I was like, oh, this is really bruised. Like maybe I should go get an x-ray. And my
Oh
doctor was like,
no.
how are you walking on this? And I'm like, oh, maybe I do have a high pain tolerance. I don't know.
Yeah, I actually had a fracture too. I fractured my ankle in high
Mm.
school, and I just you telling that story
Yeah.
just shot me back all the way to I was a freshman in high school, and I fractured my ankle, but I didn't go to the hospital
Hmm.
for days
Yeah.
to
Yeah.
get a cast on it. I was like, it's not it hurts, but okay, it's not that bad.
Yeah, I
Okay, it's
like I
broken.
said, like it hurt. I was like, I mean, it's uncomfortable. Like I definitely feel it hurting, but yeah, my doctor was like, "This is your foot's shattered. I don't know how you're walking on it." And I'm like, "Oh, well, maybe because I have like debilitating pain in other ways." That
Yeah.
yeah, awful.
Goodness gracious. Yeah. So my diagnosis came much later. I think the other reason, other than the self gaslighting and the medical gaslighting, that it would come much later is every time that I actually had a surgery,
Hmm.
they would find something wrong somewhere else.
Hmm.
So when you come out with a valid diagnosis of, oh, it was, it was
Yeah.
your gallbladder, not adhesions that had wrapped itself around the gallbladder so bad. Because when she got in there, the general surgeon, when she got in there and did that, afterwards, she was like, that was complicated.
Hmm.
Um, Not actually biopsying, for
Hmm. Hmm.
endometriosis. So
Uh-huh.
again, diagnosis missed, but also my gallbladder was dead, you
Yeah.
know.
Okay. Very similar story. That happened to me when I was 15. I got my gallbladder taken out in an emergency surgery because all of a sudden they were like, "Oh, your gallbladder is not functioning at all. Like we need to take it out right now." And in the surgery notes, like years later, I'm 27 now, and my I finally have a great doctor who's like, "Can I get all of your medical records? Like I just want to look." Um, there are notes on there that said that I had like they said I had endometriosis. They didn't tell me.
Oh my
Like
gosh.
the general surgeon had quoted on there that she saw endometrial like tissue surrounding my gallbladder, but no one ever told me. And I didn't get my actual diagnostic surgery for 4 years after that, which was a surgery I had to like beg for.
Mm-hmm.
And it was a just a diagnostic ablation, not the excision,
Oh,
because I didn't know what
oh,
it was.
yeah.
But very similar. Like I didn't find out that my gallbladder was probably due to endometriosis until like last year. It's been like 10 years. Had no idea.
Mm.
Which is very interesting that you went through
Yeah.
that as well. It's
Yeah, I
something
did.
that people don't really talk about that endometriosis can like actually take an organ.
It can take an organ. It definitely has taken some of our organs.
Yeah.
And, I was also gaslit about the gallbladder. I knew where it was. I'm in healthcare. I know what a gallbladder kind of attack or exacerbation feels
Yeah.
like. And It was only when I finally got to a female surgeon, not that female surgeons don't gaslight, they can too.
Yeah.
But I had only been seen by males who were like, oh, it's not your gallbladder. It's not your gallbladder. I'm like, yeah, it actually is. I know what it feels like. I know it is that. So I
Yeah.
couldn't even get someone to listen. And I'm in healthcare
Yeah.
for them to actually measure the right thing. They're like, no, we're going to do a colonoscopy. I'm like, no, we're not. It is
Yeah.
not that. It is the
Just do what
gallbladder.
I'm asking for.
Yeah. So I finally got to the one female surgeon that I mentioned, and I just laundry listed everything that I had done because I could no longer
Mhm.
eat fat. I could no longer process it. So you start to
Mhm.
have severe GI issues,
Yeah.
because you need fat for vitamins A, D, E, and K. And if you're not eating fat and you're not processing that, you're getting ill. You're getting
Yeah.
sick. And I was losing weight. She was like, clearly you're underweight. You can't eat like whole swaths of food types now. Like we have to do
Mhm.
something. And they did a scan and I had less than 10% functioning of the gallbladder and it was gone. But that's also just a canary in a coal mine, right? It was one thing
Yep.
they found with you, they found with me. You're the first person I've actually to meet that has a similar gallbladder story, but
Yeah,
it,
I've met quite a few, which is
yeah.
interesting because they bring it up nonchalant. They're like, "Oh yeah, I got my gallbladder taken out," and I'm like,
Was
look
it?
at,
Yeah,
I know,
and
I'm
that's
like, look
always a
at
good
your,
question.
yeah, I'm like, go back and look at your surgery notes and see if they said anything about weird tissue. Because sometime I've met a couple of people who said that, yeah, my surgery notes say that there was foreign tissue, but it doesn't say what it was.
Right. They'll
So
say
they
it's
might not
adhesions and
know,
they did
or
ablation and they,
yeah,
take it out and that can be done
very
again and
interesting.
again with no one actually biopsying or
Yeah,
letting you know that that's the case. So I always
yeah,
pay careful attention to that in all my patient populations because it may not be a lesion, but it could be an adhesion.
yeah. The gallbladder thing. I don't even, very similar. I mean, obviously, I was younger. Like, there were, at the time, my general surgeon said that he thought that my gallbladder stopped functioning or that I was never born with gallbladder function. Like, he just thought that I just never had it because I was only 15 and it was functioning. I want to say it was like 5%. Like, it was just not there.
Hmm.
Um, I don't know. I don't know if it was that. I don't know if it was the endo. Very weird. So, but it came on like out of nowhere. It was like my sophomore
Hmm.
year of high school. All of a sudden, I didn't know what gallbladder attacks were. No one in my family knew what they were. It had to do with like spicy food and like McDonald's. That's what it like
Fatty
I would
foods.
eat McDonald's and I was like on the ground, couldn't breathe, so much pain.
Yeah.
Um, so then yeah, we had to fight for them to do that test. I don't even remember what that test was, but you had to like,
That's usually a nuclear scan. It's a
yeah,
scan.
you had to like
And
drink something and it,
and they gauge the functioning of it. And
yeah.
yeah, oh my gosh. That's painful. Endo is painful. Being gaslit is painful and
Mhm.
traumatic. And so that just, added insult to injury. And I think the other thing that delayed my particular diagnosis, maybe not for
Yeah.
others, this was probably a delay. I won't say it's necessarily a good thing that it was delayed in this way, but because I practice pelvic PT, orthopedic
Mhm.
PT, functional, integrative, and lifestyle medicine,
Yeah.
I was managing the mitigating factors that make endo worse. So I was keeping endo kind of at bay
Yeah.
by managing inflammation, by managing hormonal dysregulation like xenoestrogens,
Hmm.
estrogens in your environment that can make it worse. All of those things, and of course, I spent the better part of a decade pregnant, which is varying stages of estrogen suppression in itself. Things can kind of be masked a little bit because of that. But I think that those two factors, the medical gaslighting and then finding other valid sources of the pain, as well as my own practice, helped delay it. But ultimately, it was a great thing for it to finally be validated and properly
Yeah.
diagnosed and properly excised.
Yeah. Yeah. Definitely like a bittersweet feeling too when you
Yeah.
get diagnosed with it because you are validated in the pain, but then also understanding that it's chronic and what comes with all of that. I was 19 when I got diagnosed, so I had just like a, I don't know, very weird feeling with it because I was like, oh, so I'm just gonna be in pain for like I didn't know what excision was then either, and I basically was like given this diagnosis and then was like, okay, well, we can get you back on birth control and we can talk about like freezing eggs. But other than that, like, I don't really know what else. I was in like a really rural area. But then when I learned about like, there are so many things that you can do to manage endo and like deal with pain and all
Yeah.
the things. So one of them being pelvic floor physical therapy. So,
Yeah, definitely. And all of the integrative care that comes with it.
hmm yeah. The integrative care is something that is a lot. Very confusing too, like trying to figure out how, because everyone just says, okay, like let's manage inflammation, but then it's like really hard to understand how to manage inflammation.
Hmm.
Um, so yeah. What are some things that you do for that?
Yeah. So, gosh, this kind of overlaps with so many topics that before
Yeah.
we hit the record button, we were like, let's talk about this, let's talk about that. And they all are interdependent on each other.
hmm
And so one of the first things, the way that I, in my professional and personal scope of practice in physical therapy, I've done a lot of postgraduate and postdoctoral training and different things,
Yeah.
whether it's musculoskeletal ultrasound imaging, dry needling, scar needling,
Yeah.
hormone management through lifestyle medicine, board certification in lifestyle medicine, certifications in integrative medicine, like a lot. Your education never stops, when you're in healthcare, and it shouldn't.
Yeah.
But those are some of the things that I have trained in to be able to help people manage endometriosis because it is so complex and layered. But when you
hmm
talk about the inflammation piece, that is like first stop. It's like
Yeah.
if this was a neighborhood, you're taking a right into the neighborhood of endometriosis and management of that. Once you get past the do I need expert excision surgery? And I would say, yes, most women do. They need it early as possible. And then they need intensive follow up care. You also need
hmm
some prehab appointments too for therapy, but then you need your follow up care so that we can mitigate it. And one of the first things is going to be where is your inflammation coming from?
Yeah.
Do you have it? Now, if it's pre-surgical, yes, you're going to have it. You're going to have inflammation, endometriosis. It's driven on it and runs on it, is fueled by it, creates it. It's a perfect storm.
Yeah.
So the first way that I will look at that, and it is not the only way, there are really two ways. One is by having high sensitivity C-reactive protein measured in a lab.
Yeah.
So blood lab. So we look at HSCRP first, and if that comes back and it's above 3, then we're going to start our intervention process. Now, it's not that if it's a 1, I'm going to be like, fantastic, 2 hands in the air. Let's talk about how not to have it go higher than 3.
Yeah.
So we're still going to talk about intervention no matter what. But let's say like I had someone, gosh, their labs just came in and they were like, they messaged me in the portal, the patient portal, and they're like, oh, it's not good. It's not good. All right. So we have to figure out why. What is
Yeah.
that coming from? Is it chronic stress? Is it not being able to regulate the nervous system? I mean, I think that's a chief reason quite often. How do we actually objectively measure that? Well, you can measure your 24-hour cortisol and do a diurnal, what's called a diurnal cortisol panel. It is
hmm
a one full day measurement of your cortisol levels so that we know how is your body handling stress. Now, it's not a 10-day measure. So if you get a day that's like, hey, it's, not horrible.
Yeah.
Um, but typically, if you are in stress and in pain, it's going to be kind of consistently skewed. You're not
Yeah.
going to have one good day and then like,
Yeah.
5 just horrible days. So I will measure that. And then we know how chronically activated the HPA axis is, or the hypothalamic pituitary adrenal axis.
hmm
Once we have that information, then we can start to kind of dive a little more seriously and in a targeted way towards controlling inflammation. So let's just say their waking cortisol level is really high on that lab that comes back. I'm going to talk to them like, do you wake up feeling anxiety? Is pain waking you up? Is
hmm
pain waking you up in the middle of the night? Because
hmm
that would be a good reason to have too high of a wakening cortisol response. Um,
Yeah.
but I've also had patients who their morning cortisol levels come back and their melatonin is really high. Like, and so then I ask them, can you wake up in the morning, or does it feel like there's an anvil on your head? Like,
Yeah.
is it really hard to get going? Like you hit the snooze 5 or 6 times. Then we start to do things to change that. Sometimes it's changing sleep hygiene. Sometimes it's changing like things like when they go to bed, consistency in waking up. Even
Hmm.
thermostat changes can change how our pineal gland, which produces the melatonin, and our adrenals, which produce the cortisol, they can get flip flopped. The
Gotcha.
pineal gland is like, nope, she's supposed to be sleeping right now, but it's like 8 a.m., right? And
Hmm.
the adrenals are like a grumpy old man with their arms crossed, like, get off my lawn. I'm not
Yeah.
producing any cortisol to wake her up. Then we have to do something about that. So that might be early light exposure, heating types of breathing, things like ujjayi or kapalabhati breath. Those are Sanskrit terms that just mean victorious, and skull
Oh.
cleansing. Those are heating type breaths for the system. And that takes us into like yoga and integrative medicine, like
Yeah.
Ayurvedic medicine, so that I'm able to help them manage those cortisol levels and like stimulate the adrenals. What do we need to do? Or if it's too high, how do we take it down? Do we do more
Hmm.
calming breath work in the morning? What's the morning routine looking like? And so then you begin to really embrace the lifestyle medicine aspect of what you can do. That is going to change inflammation as well. When you're changing cortisol, you're going to be able to change how your body's regulating hormones,
Cool.
metabolizing hormones. And then that speaks to things like gut health, right?
Yeah.
So, HSCRP and cortisol levels are definitely a good measure and a good read on stress management and inflammation. If the gut microbiome is persisting in like giving them problems like endobelly and bloating, for example,
Hmm.
then we may have to look at something called calprotectin. And that's looked at through a stool test.
Hmm.
So the first one would be a blood test, oh, excuse me, a urine test for the cortisol, a blood test for the inflammation systemically, and a stool test for gut inflammation. So then, you might go on to measure that. All these labs do add up. So I don't go in like, you know, all out and say we have to get all these labs done. Nope, I don't do that. We try to take one element at a time in measurement so that we don't spend a lot of money in the beginning, and they're also getting help immediately. I don't treat
Yeah.
one variable at a time. I treat all of them, but I'm not necessarily going to test all of them at the same time. It's too expensive. But that's
Yeah.
how I go about objectively measuring and then mitigating inflammation.
Okay. Yeah, that's really helpful because I feel like personally speaking, every time I go to see my provider, she's like, okay, we need to work on inflammation. Like, inflammation has been an issue. My levels have been high, but she's always asking me like, "Well, do you feel stressed? Are you stressed out?" And I'm like, "I don't know." Like, my whole life have never really I grew up in a pretty chaotic household, so I'm like, maybe, I don't know. I've never really felt that stressed about things. And
Yeah.
then I kind of started to rework like what the definition of stress actually meant. Like, not like my heart's racing kind of stress, because obviously I know I'm stressed out when that's happening, but like any kind of stress. Um, and I've noticed that, yeah, I probably am like stressed out more often than I think I am, which is interesting. And then I start to see it like in my sleep patterns. I wake up
Mm.
multiple times throughout the night. I
Yeah.
snooze through alarms for an hour every single
Oh
morning.
gosh.
Like, it's bad. I have to
Yeah.
change my alarm setting, like my alarm noise, probably once
To
a month because I
to
sleep
wake
through
up.
it. I'm
Yeah.
just like, well,
Yeah, so that would be a cortisol red flag. It's like, okay,
mhm,
inflammation could be bad, but if the first thing that I would probably work on then would be the sleep part of that. We need to get to the bottom of why you end up, night waking.
yeah.
If it's not symptomatic, like you're not waking up in pain or sweating to death, you're just
Well,
plain waking up.
one
Or
of
it
them,
could be.
I also have interstitial cystitis, which is
Okay.
a recent
Yeah.
diagnosis,
Yeah.
because that has been like the main reason that I wake up in the middle of the night, and then I feel like that messes up whatever pattern I'm in. And then I feel like it's without a
Hmm.
doubt, like every night I wake up around 3 or 4 in the morning and I like my bladder hurts. Like, it feels full, but then I go pee and
Yeah.
it's not actually. So that
Right.
has been something that has been an issue for a while and is pushing me towards an excision surgery right now because
Mhm.
kind of at a breaking point. But then I feel like I'm in like REM sleep or something at 7 a.m. when I'm trying to wake up. I don't know.
Yeah, it could be very well that that's exactly what's happening. So, from a pelvic health perspective, I will often start out from a treatment perspective of measuring vaginal pH. That is something that everybody can go out and pick up if you haven't. They are easy to find. I know Intimate Rose makes vaginal pH strips, but a lot of other people do too.
Hmm.
And if your vaginal pH is skewing towards alkaline, okay, that can actually give you a lot of IC type symptoms without even having IC. Now, it is
Interesting.
possible that a person does have IC, but if they don't have those lesions in the bladder, then they
Yeah.
don't technically have IC, but they're often diagnosed because it's a bit of a trash can diagnosis, right? In
Yeah.
fact, the term IC is being kind of shifted towards painful bladder syndrome or, bladder pain syndrome,
Yeah.
which is a more accurate way to describe it, especially when those lesions aren't there and the inflammation is not there. So one of the like low hanging fruit is test vaginal pH, and if it's off, then shift the pH back. And there are external, washes and things like that. But we have to get to the bottom of why the vaginal microbiome is so skewed to begin with, right?
Hmm.
Also, one of the number one reasons for, as a driver of, night waking, of course, yes, is frequent urination, could be driven by IC, as it is, in your case, is what is the pelvic floor doing?
Hmm.
Because if the pelvic floor is actually dysfunctional in any way, that's why musculoskeletal ultrasound imaging is, I feel like, the gold standard for measuring it. Because if I'm just doing an internal exam, that already changes what the pelvic floor is naturally going to do. But if I can
True.
observe it passively with no invasive techniques at all, I get to see, it's like I get a window into the pelvic floor and its natural habitat.
Hmm.
And I get to see how the bladder and the pelvic floor interact with each other. And
Yeah.
you can see that in real time as the patient. And that's a game changer because quite often the IC symptoms are not driven by lesions on the bladder or lesions and nodules inside the bladder or anything like that. It is driven by pelvic floor dysfunction.
Hmm.
And of course, before someone has invasive procedures and certainly surgery, we want to rule out the pelvic floor dysfunction and the vaginal pH and some of the other things that can be driving it, including nutrition, as a driver as well.
Interesting.
Yeah.
Okay, so going back to endo belly stuff, because I feel like that is a huge symptom that
Yeah.
most of us with endometriosis have. Can you explain like what endobelly even is? Like, I mean, we just say bloating, but is
Right.
it actually like gas related bloating or is it like from the pelvic floor or is it a combo?
It's such a good question. The visceral, the gut, gut complex, the peritoneum, the abdominal wall, interacting with the reproductive organs and the pelvic floor
Hmm.
is layered, like literally layered. It is also complex because there are many reasons why someone could have endobelly. Of course, the first thing that I want to go to is our favorite friend, inflammation.
Hmm.
Is that endometrial like tissue that has inflammatory, you know, um, chemicals and drivers in it
Hmm.
and can create its own inflammation? Is that causing bloating? Is it in the abdominal wall? Is it close enough to that area? Because you don't even need lesions on something in order to create a reactivity nearby that therein could cause inflammation, which then causes bloating. Because we think
Yeah.
of it as, oh, it's GI, it's GI. Well, maybe not.
Yeah.
Maybe that's the driver. Now, could we do that deeper, stool test, measurement for GI inflammation? Yep, we could do that too. Because
Hmm.
if that's high, okay, two hands in the air, we got to do something about the microbiome of the gut.
Okay.
It could also be hormone driven. Estrogen, progesterone levels as they fluctuate, during the menstrual cycle can worsen inflammation. It can worsen bloating. It can, when progesterone surges, it's going to cause smooth muscle relaxation. So, hello, constipation.
Hmm.
That's going to cause natural bloating. If estrogen and progesterone are not balanced, then you could also get bloating from that. So that's an important reason not to. It's difficult to actually track levels
Yeah.
almost difficult to impossible to track levels. But what I'm looking for is how your body is metabolizing those things. So if you
Okay.
have poor estrogen metabolism, there are labs that you can do which will indicate if you have poor estrogen metabolism. They will show up on those labs. And there is lifestyle medicine, integrative medicine that
Hmm.
you can use that will actually mitigate the poor metabolism. That will bring your endo bloating symptoms down, the endo belly symptoms down. It could also be one of the reasons for your night waking.
For me specifically, the endobelly is one of probably, well, right now, the endobelly and the bladder symptoms are my biggest issues. The cramping, the pain, like the painful cramping and stuff, I've had for so many years that I kind of know how to manage it at this point. And like the bleeding, all of that stuff, I'm like, okay, I know how to manage this stuff. But the endobelly has gotten like significantly worse over the
Mm.
years. And it almost like, I feel like I've been tracking everything so much, like food relation. I'm like, okay, is it food related? Am I causing bloating? I don't know. And it's never like TMI for everybody listening, but it's never like gas related, it feels like. I'm like, I don't feel like I need to fart. Like I don't know what's
Yeah.
going on.
Yeah.
And
Yeah.
it's like everyone's like, "Oh, do yoga poses to relieve gas." But I'm like, it doesn't feel like that. Like my
Yeah.
stomach feels hard.
Hard, tight,
Yeah.
different.
And
Yeah.
it's like it causes like breathing problem. Like I can't take like a deep breath
Deep
because
breath.
like my stomach is huge.
So,
It's
it could
crazy.
also be gut dysbiosis. Now, that goes along with kind of the inflammation and hormonal
Hmm.
changes. It could be gut dysbiosis. But what we mean by gut dysbiosis specifically is an imbalance in good and bad bacteria, or what we call commensal and opportunistic or pathogenic bacteria.
Hmm.
If you have not just an imbalance, but what if there's a parasite? What if there's bacterial overgrowth? That can happen with endo. Do we understand why it happens? No, not
Yeah.
necessarily. But we do know that the gut microbiomes of people with endometriosis are different. They are going to have less of the good bacteria and more of the problematic bacteria, which means that alone could be a reason for the bloating and other digestive issues, is because inherently there's not been enough research done yet to know what a microbiome looks like of a person with endo. Should
Yeah.
that be mapped? Yes. Is that a good research question for the next 20 years? Absolutely. That should have
Yeah.
been done a long time ago. But that's the kind of research questions that need to be asked and then answered as we move forward. But at this time, I can say I do GI maps or stool tests on almost every patient eventually that comes through, because you want to resolve
Hmm.
all the problems. You don't want to feel halfway good. You want to
Yeah.
feel all the way good. And so at some point you'll need to do that and then identify. That allows you to identify exactly what is wrong and could be the driver of endobelly. And then there's one
That's
more thing. um, Endometriosis, as you know, can also damage nerves in the pelvic area.
hmm
That can lead to irregular bowel movements and bloating, painful, uncomfortable, pressure in that area.
yeah.
But also, you can have endobelly. What if the endometriosis is actually thoracic endo? What if it's on the respiratory diaphragm?
Hmm.
Then you could actually have diaphragmatic dysfunction that makes it actually difficult to take a deep breath, to digest your food. You could have more reflux or burping or that kind of
Hmm.
stuff because you actually don't have the physical capacity to have the food pass down and through. The esophagus passing through the diaphragm can create things like gastroesophageal reflux. And that's where I have to go in and I can image the diaphragm, look at it, and then treat the diaphragm based on what I see.
Hmm. Okay.
Yeah, so there's a lot of different ways that you can actually go about treating an endobelly. Of course,
Yeah.
there's supplementation. Um, could it are medications is big pharma, the way to go for long term? Well, no, right? We don't want to be on those anti-inflammatory drugs or hormonal birth control like forever and ever. But if you look at plant-based foods,
Hmm.
supplementation, even teas and tinctures and things like that, making dietary changes, getting a lot more linear and very specific, drilled down to as to what the nutritional triggers are. I have some
Hmm.
patients actually do nutritional testing so they can determine what creates an inflammatory response in their bloodstream,
Yeah.
and that can really solve some problems. And then lifestyle changes, of course, go, that just kind of goes without saying that we're going to make
Yeah.
those things. And then, of course, always, expert excision as well in terms of managing that. But um, surprisingly, also, you got to throw sleep in there. It would be like, what does sleep have to do with GI issues? Well, if you're waking at night, your gut is supposed to be resting. Your gut needs rest too, just like the brain needs rest to clear
Hmm.
the plaques and the proteins, out of the brain at night. If we didn't need actual sleep, you could just veg out in front of the TV, right? That's
Yeah.
rest, but you actually have to get sleep. So, in correcting sleep, sometimes that also helps.
So, what about tight pelvic floor muscles? Can this make endobelly worse? Like if you
Yeah.
have just overall tightness?
Yeah, absolutely. The way that I identify that is I can again use ultrasound imaging and do
Hmm.
what's called a transperineal view, all external. But I look at a transperineal view and actually I can actually see, the anorectal canal and what it's doing and the behavior of the pelvic floor. I have seen all kinds of things on imaging where I will look at the anorectal canal, it's not the right angle. And when I ask the person to, okay, blow out without blowing out air, like bear
Yeah.
down, it actually, instead of the angle getting straighter, it gets more bent. And so they're actually
Huh.
pushing stool around the corner and uphill to get out
Ow.
because that's the opposite of what it should be doing. So that's paradoxical.
Hmm.
There's, dyssynergia issues when they go to bear down. The pelvic floor gets tighter, and I can see that too on imaging, where they'll try to empty the bowel. Bladder can be the same. They'll try to empty the bowel, and the pelvic floor, the anal opening actually closes. Well, that's not going to work.
Yeah.
So it helps to then, it also is very validating for people to come in. They don't necessarily have to get an intrarectal exam. They don't necessarily have to do anal manometry, which is like, passing a balloon in public, trying to
Yeah.
defecate a balloon. Okay,
Yeah.
that's feels embarrassing, right?
Hmm.
And maybe painful also. I can look at all of these things in a very non-invasive way that doesn't bring all of the anxiety and and things
Yeah.
that go along with other
I haven't
testing.
even heard of that. I love that.
Yeah, it's a game changer.
Hmm.
It's really a game changer for pelvic PT. So that's the test that I will use. And I can also send those reports back to physicians when they're wondering, should we do manometry testing? Well, let me look at it
Yeah.
and see if there is dyssynergia there. And if there is, it's easy to see. And we just start retraining at that point as well. So that can cause endobelly, in addition to
Hmm.
all the other things that we talked about.
Wow. So lots of stuff can contribute to endobelly.
Yeah.
Um, okay, switching gears a little bit. A lot of when I said that I was having you on the podcast, I had a couple people message me and wanted to know like why endometriosis is related to painful intercourse so often. And I know that that is like a really big question too. Like there could be a
Yeah.
bunch of things that happen with it because obviously there have been people that have said that like with penetration it's painful, but even without penetration it might be painful. Even just like having
Yeah.
an orgasm is painful for people.
Yeah.
So do you know why like
Why?
typically that would happen? Is that
Yeah.
because of tight pelvic floor muscles or
Yeah. Let's talk about sex for a second. So sex can just be touch, right? It doesn't have to be penetration. And so
yeah.
when I talk to women about painful sex, the first thing is, well, does it hurt to put on underwear? Can you wear pants? Can you sit down? Right. And
Hmm.
then I get out my model. Where's my model? It's right behind me here. So I get out my model and I say, okay, is this part, is any of this part painful at all to light touch? And of course, I can
Hmm.
test all this stuff in the clinic as well, but I really just ask them the questions first.
Yeah.
Because if that's already painful, that's something different. It could be vulvodynia, it could be vaginismus, where things are like reflexively wanting to close on attempted
Hmm.
penetration. So they can't even wear a tampon. They have to wear pads for their cycle. And then beyond that, then I say, okay, well, let's take out a uterus. Let's take out a bladder. Let's take out the rectum and our best friend here, the clitoris. And then look inside the pelvic floor and then say, okay, What hurts there? If penetration is possible, then tell me, is it the sacrum? Is it the tailbone? Does it
Mm-hmm.
feel like there's pressure on the rectum? Like you got to go to the bathroom? Does it make you want to have to go pee? Like, does it feel sharp? Does it feel dull? Is it
Mm-hmm.
achy? Does it hurt then or does it not hurt till 2 days later? Right?
Mm-hmm.
All of those questions are valid questions, including is it is there vaginal dryness? Do you have to add a bunch of lubricant and that still doesn't work? Could you be allergic to that lubricant? I mean, there are tons of questions to ask when it comes to sexual dysfunction, but the way that they are treated are going to be different. So,
Yeah.
if someone is going, it has sensitivity here, then again, I might actually back up and go, okay, whoa, hold the horse and cart back for a second here. How's the vaginal pH? Is it too alkaline? What's going on? Is there inflammation? We don't even need endometriosis lesions even in it or even
Yeah.
next to it in order for what if there was endo near the bladder? It's going to inflame the bladder, right? It's going to make it feel like IC, even though it isn't IC.
Yeah.
Same thing with dyspareunia or painful sex or painful intercourse. It could be painful, but there not be anything pathologically wrong with that area, which is good.
Yeah.
You could have lesions in or around. Some women have to have vaginal reconstruction because of endometriosis. There's a lot of stuff that can go sideways. But one of the main reasons would be also that the pelvic floor muscles are reacting in a way that's not sustainable. That's the
Mm-hmm.
kindest way that we can describe them. And so, how do I measure that? I go back to imaging again. I go back to imaging, and if I do a transperineal image, I will go the transducer, the ultrasound transducer is like right here. Okay,
Mm-hmm.
sometimes it's like right here, but then I can take kind of a cucumber slice visual, picture all the
Yeah.
way up, like the pelvis is split in half, and then I can see what's happening with the pelvic floor. So here, we'll put these organs together now. All right, so you see this on the screen:
Mm-hmm.
bladder, vaginal canal, uterus. Okay, anorectal canal here. So I see those. If I
Okay.
can measure that, the pelvic floor does two things. One, it does lift and
Mm-hmm.
close, right? It lifts and closes, but it also goes like this. So it can be like a helicopter taking off and an airplane taking off, right? So you got vertical movement of the pelvic
Yeah.
floor and horizontal or sweeping movement up towards the pubic bone, right? Towards the front of the pelvis.
Hmm.
I can see that really clearly. If that's not happening and they have pain associated with that in an attempt to use the pelvic floor, which could just be what happens during a sneeze, what happens during a cough, what happens when they talk, which is
Mm-hmm.
why my podcast is titled The Vocal Pelvic Floor,
Mm-hmm.
because the way we voice impacts our pelvic floors. So I look at all those things to determine why painful sex is happening. And then in terms of treatment, oh my gosh, there's so much that can be done
Yeah.
biochemically, which might be supplementation, it might be, the type of lubrication, it could be internal treatment and teaching them how to treat their pelvic floor. It
Mm.
could be visceral mobilization. Maybe the bladder is not moving and we need to do a bladder mob, right? There's a
Yeah.
lot of different things that it could be, contributing to. So I guess that's kind of the 40,000-foot view of why sex can be painful.
Yeah.
Could it be
Lots of different
endometriosis,
reasons.
in or nearby? Yes, it could be. But the vast majority of the time, it's going to be related to pelvic floor dysfunction or some other kind of biochemical or hormonal change that's happening. It will also happen if you're on birth control because of the estrogen suppression and the testosterone suppression that happens.
Mm-hmm.
So, yeah, while there's some good things about birth control, there's also some not great things about birth control.
Yeah.
And painful sex is one of them.
Very interesting. Definitely know what again, like birth control, it's like a map of side effects that I don't even know that might be on there. I don't even know if I've ever like read through it. I've just been like, okay, yep, that's what I need to do. I have to be on birth control, but um really interesting stuff. So, one of the other things I wanted to ask you that the listeners wanted to ask you was how to properly engage your core when like even going on a walk or something. So, um, and I felt similarly to this as well. So I feel like I have like no core muscles. I don't know how to really engage them. And when I'm out on a walk or I'm doing like a yoga class or something and they say to engage your core, I get a lot of pain, like, sorry, again, TMI, but nothing's TMI in this podcast, but I
That's
almost
right.
get pain like in my vagina. Like, not even,
Yep.
it's like, I guess I technically don't know if you can get pain in your uterus, but it feels like that's where it would be. Like,
Yeah.
it feels like above, not actually in my vaginal opening, but like deeper than that when I'm
Yeah.
trying to like engage my core. So,
Yeah.
and I've had a lot of people message me about that too, and I'm like, I have that symptom too. I don't know why. I don't know what
Yeah.
about it, but
So there's many things to investigate when we talk about that.
hmm
First of all, we need to look for the things that would cause painful sex because if you have that particular pain that feels like pain that's up in the vaginal canal here,
yeah,
right, or literally up into the uterus. Now,
yeah,
keep in mind that, let me dump all these organs out again. Keep in mind that it's going to sit right behind the pubic bone. Look how
mm,
close it is, right?
yeah,
So, can you have pain in that area? Absolutely, you can have pain in that area. Gosh, 3 kids and natural deliveries later, definitely. Um, so, what can happen there? Well, first of all, I want to know did they have kids and did they tear at all? Because any of that scar tissue will feel
hmm
horrible until it's treated. And then once you treat
hmm
it, it should be good. It can be good
hmm.
again. So I want to know if they've had any surgeries, any scars, anything at all, any excision, any gallbladder removal, appendectomy, any of those
Hmm.
things, because it could be scarred down. And that could fascially connect to the vaginal canal, which does not feel good. It can feel like it's sharp, tearing, stinging, burning, hot,
Hmm.
cold. Now, keep in mind that can also be things that make the bladder feel like that, like IC.
Yeah.
So then I go back and I look at all the things that cause painful sex. And then I'm also going to add fascial mobility into it because for those of you who follow anatomy trains, the deep front line is a common one that will be implicated. That goes all the way down to the inside of your foot, up
Wow.
the inside of your calf, your inner thigh muscles, some of your hip flexors, up in the
Hmm.
pelvic floor, through the respiratory diaphragm, and into your voice and orofacial area.
Wow.
So when you're walking and you get that sharp sensation, also note, well, is anything else tight? Does it hurt to breathe
Hmm.
deeply? Is my neck
Hmm.
hurting? Does my muscle feel tight through here? Does my
Hmm.
inner thigh and my calf muscle, is it also tight? Because as goes those areas, also goes tightness and determines what the tightness is of the pelvic floor, is going to be. So we want to make sure there's no scar tissue there. We want to make sure there's adequate visceral motility and mobility in that area, that there's not
Hmm.
any kind of endobelly, IC thing going on, and that all that, if I didn't say it already, all the fascial planes, in
Yeah.
addition to the muscles in that area, are moving. I think that's about 5 or 6 things that I would look at to determine why that's happening. But it's not unusual. Like, this
Yeah.
is so common. That symptom is so common.
Interesting. I know it's so funny, like the podcast Instagram, I'll just like post symptoms that I feel like no one else experiences. I'm like, hey, is anyone else feeling this? And everyone's like, yeah, yep. And I'm like,
Yeah.
whoa. I'm like,
There's just not
interesting.
enough conversation about
I
it.
know we just don't
Yeah.
talk about it because,
Yeah.
well, when it's also like hard to it's even hard for me. I'm like feeling the symptom and I don't know how to explain like where it is, where or what it is. So I feel like that's part of it, and then also just the taboo ness that's
Yeah.
around talking about anything that has to do with endometriosis because so many people think that it's just a period issue, that
Mhm.
people just think you're talking about your period all the time, which sure you can, like whatever.
We can do that too.
Yeah, half the population gets them, so we should talk about them. But
Yep.
yeah, interesting. Okay. One last question for you.
Okay.
So, some people may not have access to public floor physical therapists, although I do really, really think that anyone with endometriosis should see a pelvic floor physical therapist. But if they don't have access to one, what are your top 3 self-care practices that they could start with today?
Oh my gosh. One of the things that you can pick up now, as you know, with endo, you can also have hypermobility.
Hmm.
So we have to think about that. We have to think about if a woman has POTS, orthostatic tachycardia or anything like
Yep.
that. I want to be sensitive to that. So first of all, is if you're going to pick up something like yoga, of course, mindfulness, meditation, any of those practices, yoga, even deep
Hmm.
breathing exercises, you want to do it with someone who is informed. And I do have some resources on that I can share in a minute. because they need to be sensitive to what if you have POTS? What if you almost
Yeah.
pass out? What if your heart
Yeah.
rate just jumps up by 40 beats per minute? What do you do then? Right.
Hmm.
So it's not like dropping into a regular class is that easy, but there are people out there that do teach classes for that. And I have
Yep.
trained a boatload of therapists on how to use yoga in medicine and as medicine for that reason. So I would say that's my first self care practice. The second one is get serious about ending self gaslighting.
Hmm.
Like you're going to experience that out in the world, but don't second guess yourself.
Yeah.
Trust your symptoms, believe yourself,
Hmm.
just like I believe my patients' stories, and then do what's necessary to take care of yourself. If you woke up 3 or 4 times, last night because of the icy symptoms, can you take 2 hours and go into work late?
Hmm.
Can you take 2 hours off early? Or
Hmm.
can you take the day off? Can you take a sick day? Instead of
Yeah.
saying, no, I need to buck up and I just need to push through. Because at that moment, if you're actually taxing your immune system even more, you're headed for a flare,
Yeah.
right?
Hmm.
So trust your symptoms that your body's trying to tell you something that if you had a rough night or you're not feeling well, it's not because you're weak. It's because your body is screaming at you to please take a break. Cancel those dinner plans. Like people are
Hmm.
going to understand. If they really love you and care about you, they are absolutely going to understand. And if
Hmm.
they don't, well, that helps you weed some people out of your life then.
True.
And then the third, I think, because yoga can be all encompassing as a method
Hmm.
of fitness, it can get your aerobic fitness, your strength training, your meditation and mindfulness, your flexibility, your
Hmm.
stability. It can do everything. So it's not like I'm going to list tons of exercises here.
Yeah.
The third thing I think would be to surround yourself with that cloud or crowd of people that are truly supporting you, that don't second guess your invisible condition just
Yeah.
because they can't see it. Meaning, oh, you were horseback riding last week. Why are you in bed on Saturday this week?
Hmm.
Like, are you psychosomatic? This is all in your head because you seemed fine last weekend. Why aren't you doing it this weekend? Is to surround yourself with people who understand that, invisible, condition, because that's what it is. It's an invisible disability. And
Yeah.
we just don't have time to, it's not, it's kind of the same thing with racism. Like we don't walk up to black people, right? And just
Hmm.
say, tell me how not to be a racist. That's not their issue. That's our
Yeah.
problem, right? It's not their job to educate us on how not to be racist,
Yeah.
Um, it's like that. We know it's not your job as a person with endo to educate the entire world about the fact that you need a break or that you need support or that you
Hmm.
can't hold down that full-time position because you have endo. So I think
Yeah.
support, good relationships, and then knowing when to walk away when you don't have that support, because there are plenty of people out there who will love you and support you.
Love.
Um, Taking your yoga and your mindfulness seriously, um, and then not gaslighting yourself, I think are the big self care practices. In terms of like, to go back to the yoga thing, I promised a resource on that. And I just launched this, is for people who cannot afford it. And this is exactly why I did it, because not everyone can afford to like fly in and do 16 hours of intensive endo care
Yeah.
with me, which is what I do for people on a regular basis. For women who can't do that, I have 2 levels of a YouTube membership now.
Ooh.
Yeah, the first tier is, they're both inexpensive. It's $14.99 a month for unlimited access to over 40 hours of content, all taught by
Wow.
me. And it is all endosensitive. The next level is for women who are having specific issues like IC or endo. You,
Hmm.
you get access to everything that's at the base level, and then you get exclusive practices with me and live Q&As and private practices and stuff like that. That's like $29.99 a month. So I'm
Hmm.
just now launching that because, of course, A, not everyone can come to see me, but B, I want to get way more specific about the resources and tools to help women with endo. And you need to know how to exercise and what sleep looks like and what nutrition looks like. And
Hmm.
so those would be my top 3 resources. And yeah, thanks for letting me
I
shamelessly
love that.
plug the YouTube
Oh,
membership.
of course.
So
Yeah.
yeah.
That's a really reasonable price, honestly. Like when you look at how many subscriptions you're paying for and what they cost, like it really, yeah.
Yeah.
Um,
Well, thanks.
wow.
Thank
Thank
you.
you
I
so
hope
much
that
for
that's a help
it
to a lot of
is.
people.
I think so, for sure. There's just when you really, I don't know, there's just so many people that are always looking for like some type of medication or like one magic thing that's gonna fix endometriosis and help a lot. It's just really hard. Like I was in denial for a very, very long time that I was like, oh my gosh, it's just so hard. But when you go down to the base root of it and figuring out inflammation, like it really goes back to all I mean, they're all hard things, but like sleep,
Yeah.
eating, exercising, being around good people, listening to your body, like it sounds much easier than it actually is.
Yes, it
The
does.
process.
It does. Just get a good night's rest and breathe deep
Yeah.
and have a
And
good
I'm over
partner.
here like,
Well,
I'm
if it was
trying.
only that easy. It does get geeky, it gets sciencey, it gets nerdy, and I think that should be encouraging to people
Yeah.
that, when I talk about sleep science, I'm not going to just tell you to go to bed early and breathe deep.
Hmm.
That's not what we're talking about. We're going to talk about specific, elemental things that you need to shift and change in order to
Hmm.
be able to permanently get better night's rest,
Yeah.
which could mean, lab testing for that. And in some cases, maybe it doesn't. But the good thing is it's um, changing those things is technical, it is
Hmm.
evidence based, and you get measurable improvement in like a short
Yeah.
amount of time. So it's like high payoff. It's like low hanging fruit, if you will,
Yeah.
Yeah.
Yeah. They're like I don't know. They should be the simplest things, like to just go get a good night's rest, but it's difficult, but it's the things that's going to make you feel the best for
It
sure.
is. And if it helps
Um,
keep endo at bay permanently
yeah.
so that after your excision surgery, or even if you don't have to have it, that,
Yeah.
it's a one and done, and then you
Hmm.
can keep all that stuff at bay. That's what it's all about.
Yeah,
Longevity.
exactly. Longevity. Thank you so much for coming on the podcast. This was so fun. Oh, where can people find you?
Oh,
Plug
yeah.
that.
Well, you can go to at Dr. Ginger Garner on YouTube. I
Hmm.
do have a free version of the YouTube channel. You can look at some of my stories on endo, videos that I put out on endo, and all the voice to pelvic floor connection.
Hmm.
I do have my YouTube memberships on there as well if you want to subscribe. You can go to garnerpelvichealth.com. First consults are free. I am one person, so I can only see
Hmm.
so many people, but I
Yeah.
do first consults free. And then I'm on Instagram also at Dr. Ginger Garner.
Perfect. Thank you so much. This was awesome.
Thanks, Lexi, for having me. This was a
Thank
blast.
you.